Hi, I'm Matt, co-founder of Opal Health, along with Melissa Kaminka. We're a new non-profit dedicated to advancing community-led care for safer births in Uganda. We started Opal Health a month ago because we've seen that while the medical solutions to prevent the deaths of mothers and newborns exist, they're not reaching those that need them most, and we exist to change that. Today I'd like to share what we've seen on the ground and how we plan to fix it. We've just returned from a visit to eastern Uganda, and over the last 2 weeks we've been speaking to communities and government health workers and looking at data. The photo you see here is from a community focus group that we led with 18 mothers. Out of these 18 mothers, 7 of them lost newborns in the first month of life. I also spoke to a community health worker here who told me about a mother who had died on the way to hospital last year during labour. Sadly, the story here is not an anomaly but part of a wider trend. In sub-Saharan Africa, over 200,000 mothers and 1 million newborns die every year from preventable causes. We're also seeing that the key indicators for maternal and neonatal mortality are stalling and in some cases worsening. This is frustrating because we know what the causes for death are. For mothers, the 3 leading causes of death are hypertension, hemorrhage and obstructed labour. For newborns, it's prematurity, birth asphyxia and sepsis. These are well understood. And just as we know the causes, we know the solutions. So for hypertension and prematurity, it's seeking antenatal care. For obstruction and sepsis, it's understanding the danger signs. For hemorrhaging, it's reaching hospitals on time. District health officers, one of them in the area, told me that the 2 delays for mothers deciding to seek care and mothers reaching care are chronic problems for Uganda. This is where Opal Health comes in. We know that top-down instructions don't change behaviour. One village might have a problem that it's too far away from health facilities. One might have a particularly high malaria burden. One might have a cultural issue with teenage pregnancies. So we use an evidence-based approach called Participatory Learning and Action, or PLA. PLA brings women together in their community to look at their specific health data, to address the barriers that they're facing, and to come up with solutions. We provide the framework and they come up with the solutions. Melissa and I have both worked in the development sector for over a decade, and we see the potential that this model has to make effective change. Our operational model is lean and scalable because we work through existing structures. First, we train government officials, village health teams, to facilitate these discussions. Then we mobilise the groups. We bring together women, husbands, community members every month to learn about care-seeking behaviours and to identify solutions. And third, we collect data, tracking critical care-seeking behaviour and sharing this with government so they know how to target their resources. Since starting, we've identified a high-profile catchment area in eastern Uganda where we think we can work. You'll see the district shaded here. We've also secured the necessary support from central and local government to start work. We've gathered baseline data to understand how our intervention should work, and we've built a network of technical advisors to guide us. Our plan for next year is clear. We're launching our pilot at the end of February, and we'll begin with a focused scope, working with 2 sub-counties within 1 district, gathering together 200 members of groups. We're going to prove the model's efficacy and then plan to scale. We would welcome any interest in our programme or support for our pilot. Please reach out to me or Melissa using the emails on screen. Thank you very much for listening.